Next speaker, Sodeep Sen Gupta sir. He is going to talk about HRCT temporal bone and its role over evaluation of CSOP.
CMOS, chronic subtrophy
He
osteoarthritis
did
media.
his DRE from Nil Ratan Sarkar Medical College and
He's from
Hospital.
Kolkata.
He is the medical technologist in radio
Where is
diagnosis in
graduated?
Parkview
From which college?
He not
Multi-Specialty
graduated.
Hospital.
He just admission.
He has two
He.
general articles in
Speaker. Just
ISRT.
admission. You both. You both are batchmates.
Sir.
From which university?
I admission on GMC Chandigarh and he admission on Kaji Nazrul Islam University.
Radiotechnologist, MTRD.
Thank you everyone and thank you the persons who was on the dais and off the dais who can give permission to everyone to study my presentation. So the topic on which we are going to discuss is about HRCT temporal bone. So after going deep dive in this topic, I have to know that temporal bone is a very complex anatomy we have to know. And on that time, a minute changes in our every pathology can cause disruptive effect in like in human change in anatomy. So, after going through HRCT temporal bone, we have to know what is HRCT. HRCT stands for High Resolution Computerized Tomography, in which we didn't take thick slices. We take thin slices, and on that we are counting each and every photon particles of X-ray in a detector alignment. So to get a better spatial resolution, to get a better delineation of bony part, as because we are talking about HRCT temporal bone, they are minute structures like ossicles and all. So on that thing we have to be very care of that is there any erosions that we are dealing with today? Is there any erosions in the pseudomelius joint or is there any erosion in the plate of Tura? So regarding this topic we discuss on that. So what do you mean by HRCT? I have already told you that HRCT stands for High Resolution Computerized Tomography. But the thing that everybody will miss, most of the people will miss, that we are taking slices in a bit of 1 mm and we have a thought that we can recon it with a 0.65. But is it not true? Until unless we can do the entire raw data in 0.623, then after getting the recon, we only get the separation of the values of raw data after the image acquisition. So all of the thing is a total and total to be a unified image, and that scheme that when we go for a like image, when we go for a city image, we think that these are the sequential images and all, and we do a recon on that, and we get a sequence image on 0.625, or we can go 0.5 more lower than 0.625. But this is actually the separated image of the raw data, and we can't get the actual raw data which is been acquired by the accumulated value of at a scale level of 0.625. So objectives of HRCT are to produce high resolution computerized tomography to better differentiation and contrast, bony detail and pathophysiology and on-standing effect of pathological changes. Like as I said that COS, chronic suprahepatic otitis media, is a major cause, like people who are in the unhygienic places, unstanding, like not being in a hygiene condition, somebody like degenerative changes occurs in the in various important parts in the inner ear, like ear ossicles, plate of crura, tegmentum tympani. This affects the other pathology, other parts of the human body regarding or in the circumference of that mid brain, mid ear. So this is an example. Let's discuss. So as a technologist, we have to know the scan parameter for like HRCT temporal bone, and as we have seen, the position should be head first 2 points, next thickness should be 0.63, is here is 0.629, and slice thickness of 1 and 1.23. The focus should be 9 to 10 mm temporal bone for temporal bone, and its exact is to be like above the temporal suture, temporoparietal suture, and below the TM joint. So that some people has the extended mastoid ASL sinus tubercular formation in the lower side also. So if we can't like take those part, there must be a misregistration for that. And also the KV should be 120 because we are dealing with a high mean attenuation beam energy here for a high like bony structure. So we didn't care for the like affecting a lot of KH values in that way. And high MA is there. High MA is used for better penetration, so that we can easily delineate each and every structures like plate of crura, both foot plate and the entire stapediomalius bodies like short process and long processes. all those things we have to better delineate in every any images. The matrix size is 512 by 512. It's depend on the FOV you have set. The pitch should be very less, as because we are using a thin slices. The doses increases, and pitch should be to decrease the scan time and also to get a better resolution with low dose effect. So this is that's all the patient is positioned head first supine, and this is the scan parameter has been done and image acquisition is getting. So this is not at all the entire case. When we are going for this is only to get the acquisition or only to get the rod out of the axial slices is not at all. Previously, when reformats or three planar reconstruction was not there, when we were using dual slices, single slices, then on that time volume viewer reformatting is not there. So we have to take different angulation planes like Zencroft plane, and for that basic better ocular view, the thickness of the ocular semicircular canals, which may leads to a conclusion to yes, this is the case of COSM, or yes, this is the case of cholesteatoma. So if we go for this is a normal study of a temporal right temporal. You have said the master ASL sign. This is the normal study of HRC temporal bone or right temporal bone. Here is the master ASL sinus, trabecular formation is very good, temporal mandibular joint, external artery canal, interauricular canal, the air ossicles is there, the integumentum tympani, and the master and the entire part of the greater sphenoid bone. So this is the normal study you have seen regarding all the structures of the inner ear, middle ear. And when we go for CSOM, so what is CSOM? CSOM is chronic suppurative otitis media, which is primitive stage of acute acute otitis media, which is like inner ear infection. So this is how this is caused. This is caused by basically a long-standing upper respiratory tract infection from bloodborne and any other like congenital also. You can take if a patient is in unhygienic condition, he will go for a false we go for a false positive. We have a patient has a color already discharged from his ear and it has a foul smell. So on that thing, the people will, the ENT department will get the declaration that he or she might have a CSOM or some other kind of pathological changes. So on that time, the test is if the bacterial growth are there, like Pseudomonas angiosum, Staphylococcus aneurysm, Streptococcus, and E. coli and Proteus. These are the organisms which are mainly dealing with occurrence of CSOM. And on that thing, the main the organism that Pseudomonas angiosum is responsible for morbidity and mobility of cystic fibrosis, along with leading effect on the property of degenerative changes to the ear oscillator, that is the cholesteatoma. So there are the definitions of CSM, and the CSM is produced in the inner ear that may lead to a formation of ulcer. To prevent this ulcer, our body regenerate or form some granulations to that mass effect caused by our body itself. That is the resistiveness of the body nature, and it will cause formation of tissue and also the formation of polypoidal effect to the inner ear, gives obstruction and hearing loss. So that affect the general indications like ulceration, granulation of tissue, mucosal edema, cholesteatoma, osteitis, and ocular particularly EAC, external auditory canal. So this accumulation of mucosal cells and mucosal appearance, polypoidal appearance is a resistive nature of human body to prevent the ulcer and to form the granulation inside there. And we can easily say that after ulceration formation, or if in the primitive stage of CSOM, that person is resisting the bacterial growth by the normal action of body. So cholesteatoma is like congenital and acquired cholesteatoma. Congenital is hitting the abnormality defect in human body, which leads to congenital CSM. Actually, it's not like CSM, like otitis media. CSM when the turns to be like acquired from some hygienic condition, from like long-standing upper respiratory tract. In some cases, it will change that if the patient have like long-standing tuberculosis. On that case, some patients come with cholesteatoma, facial palsy. So how facial palsy is occurred? If it is totally affected the inner ear, how facial palsy will be a part. Because in ear, when we learn about inner ear has the main important structures like jugular foramen, all the branches, main three segments like cisternal segments, canalicular segments, tympanic segments, and labyrinthine segments of the facial nerve. So on that thing, if that part infection goes to that nerve or the facial nerve, it causes facial palsy and different other degenerative changes to that regard to that facial nerve. And these are the few examples in which you can see the proliferation of in the middle ear. This include over there the decrease of the tuberculi in the mastoideal sinuses. That part you can say the growth of the proliferation in the inner ear and also the erosion of the pleura also. The pleura space, the pleura and the tegmentum tympani. These are the main important sections that we have to go for an CSOM invasion. And if we go for CSOM, there are two methods or the two categories we can define CSOM. That's first we call anticoantral CSOM, and which is called unsafe CSOM, and the second one is called centric and the safe CSM, that is called the central perforation of the pars tensa. The central perforation of the pars flaccida is responsible for our secondary or unsafe CSM, and the safe CSM. And the unsafe CSM is responsible for perforation of the pars tensa. On that thing, it will directly affect the ear ossicles and cause erosion that leads to cholesteatoma by creating a retracting pouch in the tegmentum in the tympanic membrane, and retracting pouch will lead to the invasion to the inner ear. And if it is invaded to the inner ear, it will cause its granular formation and other resistive action of the body. And on that case, the gradual hearing loss will occur, and that will lead to various effects like cholesteatoma in the inner ear, erosion of the ear ossicles, deviation of the jugular bulb. That will lead to all other secondary effects that may cause it to affect on those important organs, like cochlear promontory erosion, semicircular canal erosions. That also leads to the effect on, like, as you know, that in the inner ear there is a structure called crista falciformis that gives a section to the anterior and posterior segment, which gives branches of auditory canal, vestibular, posterior segments to the vestibular nerves, and anterior to the auditory canal and facial nerves. So this segment, if it affected by the cholesteatoma, it will cause degenerative changes to those particular organs which are responsible by or which are stimulated by those nerves. Like as we are giving the example like facial palsy and also. And in these images, like you can say, the erosion of the air in the external air, the tegmentum tympani is also affected. This is mesotympanum. This is mesotympanum and the entrance of the audiatus adentrum. And this part due to the ice cream cone appearance of the infundoseparator joint of the malleus, malleus and the head of incus, and short process get eroded, and that space is totally covered up by the mucosal granular growth. So you can also see that this is the part which is affected by CSOM. That is actually we can include that. We can say that this is the part which is affected by the cholesteatoma and formation of granulation over there. Now you can see an example of HRCD CSOM. You can see like that this part is already get that pneumatization is totally disrupted. The growth in the internal auditory canal is there, and the temporomandibular joint is there. The sclerotic part is also been seen in the lower segment of the left temporal bone. And this is all about the mesotemporal still affected. The ear ossicles. This part is the labyrinthine segment of the lateral sensory canal is also affected. The part of the Peyer's bone is also affected. This is the coronal section. You can see that part. You can see that erosion in the focal direction over there, and also this is the hypotympanum, this is the radius adentrum, this is the epitympanum caused to the this is the facial nerve bruises. We have found the foci over there, and the erosion in the mastoidal ASL sinuses with the loss of clavicular formation and sclerosis to the mastoidal ASL sinuses. This is the this is another example of a patient with a bone window. Sorry, this is another patient with a bone window. This is the axial cuts. You can see see the bone. Actually, this is a sinus window. For that, we can easily see the granulation formation or mass effect on the part of the temporal bone which has been affected. Actually, we always study the both bilaterally because it will help us to get the symmetric information. And if the patient is already a congenital anomaly regarding that, we can easily differentiate between all those things. So if you find that the malleus in the joint is intact over there, and in this case the right temporal is affected. So in every case, like CUSM is a very deep dive structure to be driven on, but to get an overall view, the CUSM has a category, or CUSM is formed by three processes, like Wetzman theory and Brady's theory and Hartman theory. These are the three theories from which CUSM formation has been explained. Somebody says that in Hartman theory it says that CUSM forms the basal epithelium cells of the external external foot plate of Flora, and from that granulation formation occurs, which leads to extension of those cholesteatoma and all infected changes. And in and that's all about CSM. And these are some of the examples in which you can see the sclerosed, the well pneumatized cells in the right temporal, and there's the effect of CSM in the left temporal part, along with the accumulation of granulation in the external auditory meatus, along with the erosion effect in the cochlear promontory and the semicircular canal. That's it, and that's how I conclude my presentation. Thank you everyone.
Thank you very much, Pastor Gupta, for this wonderful presentation. Any question from the audience?
This is not a question, just a comment. I appreciate your presentation, understanding, because temporal bone is not easy. Only comment is ki you have done very well with presentation and all, but don't stretch the images like this. So the actual image was pulled like this. But that is not the way a radiologist or radiographer should do. So it should be always enlarged by a corner so that the symmetry is maintained, length is too great. Otherwise it was leading to anatomical distortion. So this is just to learn for everyone.
Thank you, sir, for this amazing presentation. May I now request our chairpersons to present the memento to Mr. Sandeep Sen Gupta.
Sandeep Sen.